Again, I am I'm Leslie Appiah, and I am the co-director for the Fertility Preservation and Reproductive Health Program at The Ohio State University and James Cancer Hospital. And it is my pleasure to speak with you this morning on contraception and timing of conception in gonadotoxic therapy. I have no financial disclosures or conflicts of interest. My hope is that at the end of the talk, you will better understand the effects of cancer treatments on gametes, embryos, and offspring, that you will feel a little bit more comfortable with the discussion about contraceptive options during and after cancer treatment, and that we will better be able to identify, hopefully, the appropriate timing for conception after cancer, or at least have a little bit more of a discussion about it. To illustrate, this is a 19-year-old G0 with stage 4B classical nodular sclerosing Hodgkin lymphoma who presents for fertility preservation consult. The initial plan for chemotherapy was adriamycin, bleomycin, vincristine, and doxorubicin. After discussion, due to the perception of low risk of infertility from the ABVD therapy, the patient declined oocyte or ovarian tissue cryopreservation. She subsequently received a second opinion regarding her cancer treatment and was placed on Children's Oncology Group protocol with BIACUP due to a higher 5-year event-free survival. The patient was enrolled in one of our research studies, therefore baseline AMH and FSH were drawn and were within normal limits, and she was cycling regularly. So over the last several decades, the incidence of cancer has risen slightly to about 1.7 million new cases per year. Of those, approximately 70,000 persons in the U.S. are between the ages of 15 and 39 or of reproductive age. Due to advancements in cancer therapies and early detection, survival rate for pediatric cancers is at its all-time high at 85%, but for adolescent and young adults of this reproductive age group, survival is a little bit lower, 70%, and that's due to differences in tumor biology, access to clinical trials, access to care. Current cancer treatments are multimodal and include agents that can affect fertility. Similar to the effect of on other developing cells, chemotherapy affects the maturing follicle. This is a follicle that produces estrogen. So during cancer treatment, patients will become amenorrheic. After completion of chemotherapy, when that insult is removed, follicular genesis resumes and patients begin to undergo ovulation. For patients who receive alkylating agents and radiation therapy, the primordial follicular pool is affected. So this is the resting non-growing follicles for which alkylating agents are non-cell cycle specific, so they affect these cells. So these patients will have a depletion in their ovarian reserve. When the chemotherapy or radiation insult is removed, these patients will potentially undergo follicular genesis and ovulation, but it's important to remember that these patients will ultimately have a shortened reproductive window and experience exhaustion of follicles very early on. In terms of the effects of chemotherapy on sperm quality, we know that the genetic damage is induced by DNA cross-linking and single-strand breaks. The spermatogonial cells have an excellent repair mechanism, so most mutations that occur in the spermatogonia are repaired or removed via apoptosis. However, sustained mutations may result in production of mutation-carrying sperm for a lifetime. The spermatogenic cells that are further along the differentiation pathway typically cannot repair DNA damage as well as the spermatogonial stem cells. Therefore, ejaculated spermatozoa may harbor extensive genomic damage. Meistrick, who is in the audience, has described the effects of chemotherapy and radiotherapy on spermatogenesis in humans. And what he has illustrated is that testicular involution leads to azoospermia typically within 3 months, and that is evident on this first graph here. Similarly, he has described that after chemotherapy, the return to function is delayed and can be upwards of 72 months, and this is not always reaching normal. Mike also describes that with patients receiving radiation therapy, there's also a similar loss of function below the into azoospermia within 2 months. It may take several months to recover, between 18 to 36 months, and then patients subsequently have recovery. So time to recovery after pelvic radiation therapy and chemotherapy in these patients can range from 12 to 72 months. And we've had a little bit of a discussion of that yesterday in our discussions. So DNA damage causes several different problems. So the initial problem would be difficulty with fertilization. So patients will experience infertility due to difficulty with fertilization. For those patients that are able to have successful fertilization, there are some reproductive outcomes that are not desired, specifically problems with embryonic development, so early miscarriage, and then there have been reports of childhood diseases as well, birth defects, micrognathia, hydrocephaly, and then some problems with fertility itself. So in terms of the effects of cancer treatments on the actually developing fetus, Dr. Jarris described this very nicely, and I'll just do a quick review. Patients who experience chemotherapy early in gestation, in this pre-implantation or early post-implantation phase, have an increased risk of fetal death. So with the early first trimester, we see a miscarriage. During the late first trimester, during the embryonic and major organogenesis phase, these patients will have a 20% risk of major malformation, so up to 20%. And then, as Dr. Jarris described, term is typically a safe time to receive chemotherapy. However, there can be some impairments in growth and development. And so the consensus is that the second trimester is the safest time to receive chemotherapeutic agents. And again, not all chemotherapy is safe during cancer treatment, and Dr. Jarris described that cyclophosphamide, adriamycin are safer, taxanes controversial. So what we do know, however, is that when patients are remote from their cancer treatment, that the offspring do well. So there are studies early in 1970s by Lee and colleagues where they assessed 240 study progeny, and they showed that the incidence of fetal chromosomal or congenital abnormalities after chemotherapy remains the same as the general population. Dan Green also described in the late 1990s that in 200 pregnancies with 300 subjects that there was no relationship between the number or cumulative dose of mutagens received and the frequency of congenital anomalies in offspring. And so we know that when we can space out the time of siring a pregnancy for males and gestating for females, then we have an improved progeny. So we know that there are risks to chemotherapy to the gametes, and we know that there is risk of chemotherapy and radiation to the developing fetus. So then how do we adequately counsel our patients on the safety of contraception in these patients, very delicate patient population with multiple risk factors? So the Centers for Disease Control and Prevention in 2010 developed the medical eligibility criteria for contraceptive management. These criteria are based on the World Health Organization's criteria and have been modified to meet the needs of the United States population. In 2016, there was an update, so the most recent document is of 2016 and address special populations. So category 1 are those contraceptives that have no restriction for use. Category 2, advantages outweigh the risks. Category 3, the risks outweigh the benefits. And category 4 contraceptives would be an unacceptable health risk if that contraceptive method is used. So to briefly describe the contraceptives that are available and their efficacy, the least effective contraceptive, and you would know that, it would be withdrawal and spermicides. These are considered tier 4, very not effective. There are about 30 pregnancies per 100 women in 1 year. The third tier contraceptives are barrier contraceptives with an 18 to 28% failure rate. Tier 2 includes injectables and hormonal contraceptives such as the pills, patch, vaginal ring, and lactation amenorrhea. However, the failure rate is still pretty high at 8 to 9%. And then tier 1 are optimal choices with a failure rate of less than 1%. And that includes contraceptive implants, the contraceptive device, intrauterine device, female sterilization, and vasectomy. And of note, the most effective contraceptive agent is the implantable rod. That would be our older Norplant with the 7 rods, and we currently have 1 single rod. And the reason that is more effective than even permanent sterilization is that there's a device in the arm. The device can't leave the arm. It may migrate, but it remains in the body, and therefore it's going to be more effective than any other form of contraception. So in 2013, the American College of Obstetricians and Gynecologists put out a consensus statement on some of these tier 1 contraceptives. And this is a practice bulletin that we refer to in our practice. And what they state regarding long-acting reversible contraceptives, that's the implant and the contraceptive device, the intrauterine device, are that IUDs and the contraceptive implant are the best reversible methods for preventing unintended pregnancy, for preventing rapid repeat pregnancy, because it's preferable that women space out their pregnancies, and for decreasing abortion in young women. They go on to say that LARCs should be considered first line and offered to all reproductive age women, including adolescents. And this was very important because what we don't prefer to do, or what we shouldn't be doing, is offering pills and a patch in the ring, and then when patients fail that, either with a pregnancy or because they can't remember to take it, then we say, oh, how about a LARC? Maybe you should use an IUD. We want to offer these things up front, and of course it depends on the age of the patient, but LARCs may be used in adolescents. Specifically, the intrauterine device may be used in adolescents. For some patients, we place them under anesthesia if it's necessary. Obviously, those are not patients that are necessarily contracepting, but it is an option. I want to make that very clear because even in our OBGYN world, there are adult gynecologists who do not believe that IUDs are safe for adolescents. And so all of you now know that they are. So to describe the Etonogestrel implant, this is the implant that goes in the arm. It's a single 4-centimeter rod. It contains etonogestrel, progesterone only, and is effective for 3 years. And again, it is more effective than permanent sterilization. It goes in the arm about 8 to 10 centimeters from the medial epicondyle, and there were no pregnancies during the 1,200 women years of exposure. And it's very simple to place. In terms of intrauterine contraception, the copper IUD is non-hormonal, 10 to 12 years effectiveness, and there are no hormonal side effects, so this is a benefit for many patients, particularly our breast cancer patients. The downside is these patients tend to have heavy bleeding at insertion and then over time return to normal menses. So for patients who have heavy periods, this is not always preferred. And again, so it is the most effective emergency contraceptive agent, and that's important to know for patients who have had unprotected intercourse within 5 days, that this is an option for them and it's the most effective. In terms of the hormonal intrauterine device, the levonorgestrel IUD, the effectiveness is 5 to 7 years. So for younger patients less than 40, we quote 5 years effective rate, and for patients over 40, the effectiveness is up to 7 years. Patients may have irregular bleeding and cramping for the first 3 to 6 months after placement, and then typically begin to experience amenorrhea, 20% in year 1 and then 70% by year 2. And there are some systemic effects, but it's mostly locally acting, so patients don't tend to have symptoms. There is a sister of the long-acting levonorgestrel IUD, and this is try not to say any brand names, but this is a smaller device. It's a little bit shorter and thinner, and it's 3 years, also containing levonorgestrel in the system. The downside to this, the smaller device, is that patients tend to have menstrual cycles. So to talk specifically about different categories of patients that are at high risk, breast cancer patients are the ones that I think we think about the most when we think about contraception and which contraceptive agent is safe. And so in looking at breast cancer patients here, so patients who are currently diagnosed with breast cancer, I'm just going to step here for a second. Patients who have been currently diagnosed with breast cancer, the copper IUD is considered the only safe device to use. And as you see here, all of the other hormonal therapies are considered category 4. Similarly, for past use with no evidence of current disease, the copper IUD is safe, and the remainder are considered category 3, where if that option is the best option for that patient, then you could certainly consider it. And I just want to go over some data about levonorgestrel IUD versus copper IUD, because there's a little bit of controversy there despite the CDC's recommendation. So this was a retrospective, population-based, case-controlled study conducted abroad in Germany and Finland of women under the age of 50. It was powered to exclude a greater than 1.5-fold risk of breast cancer. There were 5,000 respondents with a response rate of 68% with breast cancer and 20,000 matched controls. And what they showed is that the odds ratio for patients who are current users of levonorgestrel versus copper IUD was 0.9. As you can see, it did cross unity, so not statistically significant. So there was no increased risk of breast cancer in patients who had used the levonorgestrel IUD versus the copper IUD. And then for those who are currently using. Similarly, for those who had ever used either device, again, the odds ratio was 1, crossed unity, therefore not statistically significant. So what they concluded in this very large population-based study, that there was no indication that the levonorgestrel IUD is associated with an increased risk of breast cancer in women younger than 50 who had either previously used or currently used the therapy. However, the recommendation still remains that the copper IUD would be standard for these patients because there are some systemic levels of the progesterone in the system with the levonorgestrel IUD. And I have seen the breast oncologists go either way depending on their patient, and receptor status doesn't seem to really play a role in this. There's some concerns that even with receptor negative breast cancer that the levonorgestrel IUD may still be problematic. So I just wanted to show the data on that. In terms of cervical cancer risk, for patients who are presenting, who are diagnosed with cervical cancer, the I stands for initiation, C stands for continuation. If they present with an IUD in place, the IUD does not need to be removed until their definitive therapy. However, it would be inappropriate to place an IUD in a patient newly diagnosed with cervical cancer due to the risk of infection, perforation, and expulsion. All other contraceptive agents would be amenable and would be safe. Similarly with endometrial cancer, again, if the patient presents with an IUD in place, it may certainly remain until their treatment, but you would not place an IUD at that time for similar reasons. And again, there are no hormonal contraindications for patients who are diagnosed with endometrial cancer. They can certainly use these contraceptive agents. Ovarian cancer, as you can imagine, there would be no contraindication to any of the contraceptive devices. And then solid organ transplant. For those patients with complicated solid organ transplant, so showing signs of rejection, again, if the IUD is in place, it may remain. You would not place it at that time due to risk of complications. Important to know that combined hormonal contraceptives with estrogen are considered category 4 in these patients, and that's due to the risk of cholestasis and some worsening of disease. The caveat with these recommendations are that these are based on case reports. So 4 case reports only are what describe our risk in solid organ transplant. Uncomplicated transplant, certainly you may use all contraceptive agents. So the bigger question then is, what about Hodgkin's lymphoma and sarcomas and Ewing sarcoma patients? Is it safe to use these agents? All of the other hormonal contraceptives would be safe, but the question becomes with the IUD in the setting of immunosuppression. So we have limited data on the copper IUD and the levonorgestrel IUD in women who are immunosuppressed due to cancer treatment. However, we extrapolate from the data of patients who are immunosuppressed from HIV, where we have a lot of data, and for patients who are immunosuppressed while being treated for SLE, lupus, where we have a lot of data. And in those situations, it's category 1 and 2. So it would be safe to use a LARC in those patients. Similarly with uncomplicated solid organ transplant. And the one caveat is, again, timing of placement. If a leukemic patient presents and their ANC is very low, that is not the time that you would place an implant. You would wait until after induction when the counts have risen and then place the implant at that time. But then it would be considered safe. In terms of emergency contraception, the copper IUD, again, the most reliable emergency contraceptive agent, can be used within 5 days. Ulipristal is an anti-progestin, again, within 5 days, so that's the most effective pill for patients. There's a levonorgestrel pill and then a combination of birth control pills. So timing is very important for your patient. If they present and say, I had intercourse 2 days ago and I'm on my chemotherapy, what should I do? These are the options. If they present and they had intercourse 4 or 5 days ago, then these are the options here. And it's important to know. There are no studies to address the use of emergency contraception directly in women with cancer or who have undergone cancer treatment. However, we feel that it's safe because it's a short duration of time. These patients are taking 1 pill, 1 or 2 pills. Now, should they desire to use this as their form of birth control, then you have to kind of determine if that's safe or not. But for most patients, a short duration of use is safe. And again, the copper IUD is considered safe except in complicated solid organ transplant and in the setting of cervical endometrial cancer at diagnosis. I'm going to briefly talk about male contraception just to be fair and balanced. Early on in the 1990s, there's been a long search for male contraception. The World Health Organization put forth a task force, 10 centers, 7-country study, and 270 healthy, fertile men willing to take IM testosterone weekly. And what they observed was that 157 of the men were azoospermic in 3 consecutive semen samples, and that the mean time to azoospermia was 120 days. The cumulative rate was 65% at 6 months, and the time from azoospermia to recovery after discontinuation was 3.7 months, and that there was 1 pregnancy during that time. And so they equate that contraceptive efficacy to that of an injectable hormones for women, so Depo-Provera. What were the discontinuations for? Due to lack of azoospermia, 6 months in some subjects, and then the weekly administration. No one desires to have weekly administration of any medication, and then of course this lack of injections. So some of the challenges to develop a male contraception, because again, besides vasectomy, we don't really have great male contraceptives currently. Some of the challenges are complexity of the male reproductive system. So the blood-testes barrier makes it difficult for hormones to traverse that barrier. The supposition that male contraception is not necessary due to availability and safety of female contraception. So we have all of this great female contraception. So pharmaceutical companies ask themselves, well, why would we put money towards male contraception when there's so much effective female contraception? But as we can see, due to many different medical conditions, there are many reasons why a woman would have difficulty with hormonal or non-hormonal contraception. So of course, we need to continue to pursue male contraception. There's also the myth that men are unwilling to take contraceptive pills or injections, and there was a study that showed that they would be willing to do that, not weekly injections, but perhaps every 3 months, similar to Depo-Provera. And of course, concern for effect on libido and sexual functioning, because that is always a concern. This is just a slide just to show the different contraceptive options that have been explored. The one that is most explored is Depo-Provera combination with testosterone. The Depo-Provera prevents spermatogenesis, and the testosterone gives add-back hormonal support so that there aren't those effects of decreased libido and muscle wasting, of course, as well. And then there are just a lot of other therapies that are used that affect either spermatogenesis or affect the function of the sperm. Some of the more promising ones are some surgical options, so insertion of a polymer gel injected into the vas deferens. It's reversible. Some vaso-occlusive devices which result in partial or complete reversible obstruction of the vas deferens. Some subdermal testosterone implants are in phase 2 trials. This therapy here is in phase 3 trials abroad, and it's also patented in the US. And then the intravas device has been FDA approved for clinical trials. So many of these options are in the trial phase. Nothing has really proven itself as of yet. So we know what the risks are to gametes. We know what the risk is to the developing fetus. We know that we have really great contraceptive options. So then how good are we at actually counseling our patients about these options? So there are about 2.8 million unintended pregnancies per year. in the United States, and 42% of those end in abortion. Now, this rate has gone down, thankfully, due to the implementation of long-acting reversible contraceptives, but it still remains a problem. And unfortunately, 50% of women who are having abortions report using contraception in the month that they became pregnant. So they were using pills, barrier, using things inappropriately. So it's very important that we contracept patients effectively, particularly this very special population that we care for. So there is a paucity of data on contraceptive counseling in cancer patients. So Britain this year conducted a study, a systematic review of contraceptive use and counseling in women. 657 articles were reviewed, and out of those, only 16 actually discussed contraception and counseling. And what they saw was that women both feared pregnancy and feared hormonal contraception, that both would threaten their health. So they were on both sides of the aisle in terms of their concerns, and those concerns were not addressed. They also found that despite having no clinical diagnosis of infertility, some women believed they were infertile and thus did not use contraception. So many patients, when they hear that cyclophosphamide or any chemotherapeutic agent is going to decrease your fertility, they hear, I am infertile, and then, of course, don't contracept. So we have to be very clear about our counseling to our patients. And then lastly, women with cancer are not consistently using contraception in alignment with their pregnancy goals. And this just reviews some of those studies. Dan Green with the Childhood Cancer Survivor Study looked at 1,900 women and unfortunately found a 17% abortion rate in those survivors, which was higher than their sibling cohorts. In 2009, Weiner conducted a cohort sampling and also found a 20% abortion rate, similar to siblings and general population. In a questionnaire by Thews and colleagues, 17% never had contraception questions answered, even when they directly asked about it. So they asked and then they were ignored, and that's a problem. Thankfully, there are some studies that show that when we do counsel patients, they actually take our advice and are more likely to use Tier 1 and Tier 2 contraceptives. So women were 6 times more likely to use LARCs or even Depo-Provera contraception when counseled, and Dominic showed that with 65% of patients in his study received contraceptive counseling with a 7-fold increased utilization of highly effective methods. So our patients don't know what to use if we don't counsel them appropriately, but when we do counsel them, they typically make the right choice. Dr. Anazato and her colleagues in Australia conducted a meta-analysis of the miscarriage rate and pregnancy outcomes after systemic therapy in breast cancer. This study was 4 matched cohort and case control studies of almost 1,300 women, median age of 33 years, who received systemic therapy after surgery. And what they found was a decreased pregnancy rate, 14% pregnancy rate, but they alarmingly found a 21% termination rate. And so, again, counseling the patients appropriately about their risk is vitally important. And so I also don't want to presume that only GYN providers do this well and everyone else fails. So this is at our institution at The Ohio State University. What our GYN oncologists did was they looked at how well they did at contraceptive counseling, and they conducted a retrospective chart review of 240 patients with fertility potential after initial consultation and treatment. The median age was 31 years of age, 45% of initial consultations, and 20% of follow-up visits included documentation of a contraceptive plan. So less than 50% of patients presenting to OB/GYN-trained GYN oncologists had a consultation about contraception, and less than 20% of those at follow-up visits had that discussion. And what they found, unfortunately, was a pregnancy rate of 11% after initial consultation. So after being told that you have cancer and you are going to receive chemotherapy and you are going to have surgery, patients then went and had intercourse and conceived, which complicates their therapy. So we all need to do better about counseling our patients. And of the patients who were using contraception, only 12 out of 200 were using reliable contraception, so long-acting reversible contraceptives. And the authors appropriately acknowledged the need to use this data to improve their processes. In terms of adolescents and risky sexual behavior, adolescents that are cancer survivors or have cancer are just like any other adolescent. So in this survey of 300 adolescent survivors ages 15 through 20, they found that they engaged in risky sexual behavior at rates equivalent to their sibling controls. Some of that is lack of knowledge, and some of that is just testing it out. Well, they said I was infertile, am I? Or I'm going to live life to the fullest. I've had this diagnosis. I'm going to do everything that my peers do. And so we have to counsel our patients. Yes, some people feel sickly, and yes, some people are too tired to engage in intercourse, but we know that a lot of patients, this is important to them to have this intimacy, so we have to contracept appropriately. And some factors related to decreased likelihood of sexual intercourse: CNS tumor, no prior history of alcohol use in adolescents, and then few negative peer influences. So we have to strive for that in our adolescents. And so once we determine that patients are ready to conceive, or patients determine that they are ready to conceive, what is the optimal timing of conception? And we've had a lot of discussion about that. Dr. Jarris talked about that today, and Dr. Chemoradiation talked about that a little bit yesterday about the males. So there are several kind of drivers for timing of conception. And one of the main drivers is cancer recurrence. Unfortunately, there are no national databases that describe, that kind of list out the recurrence rates for different cancers, but we know that it's going to depend on tumor characteristics, it's going to depend on stage of disease, treatments received, so it's going to be very individualized what that risk is for that patient. For instance, a patient with early stage breast cancer may have a different recurrence, for instance, someone with positive nodal status, right? So we just have to look at every patient individually and then determine that. On average, the time to monitor for relapse for most cancers is 2 to 5 years. Again, some populations can conceive before that time, but that's the average time that oncologists typically will monitor. And of course, there's long-term surveillance. I also want to point out that there's a 15% increased lifetime risk of developing a second primary cancer. So as Dr. Chemoradiation described, when we see these patients and do a physical exam, we need to be doing a complete physical exam to make sure there are no other secondary cancers that we then need to factor into our decision about cancer recurrence. The second important driver is going to be the maternal health or the male health. So before a patient conceives, they should see MFM or some other reproductive specialist to determine if it's safe. Do they have good renal function? Do they have good pulmonary status? Is there good cardiac status? And so that's going to be another driver as to when it's appropriate to conceive. And then I think the one we all think about and care about a lot is the follicle. When is the follicle kind of receptive to fertilization? And so what we know is that the growth span from primordial to pre-ovulatory follicle is about 6 months. And during that time of development and growth, that's when there's risk of mutagenesis. And so when patients receive chemotherapy, we want to wait, as far as we know from the literature that we have, at least 6 months before we recommend that a woman conceive with her follicles. So the recommendation through the literature currently is to delay conception for 6 months after completion of therapy in terms of the follicular integrity. In terms of males, very controversial. Dr. Brannigan and Choi describe some of the difficulties here and state that reproductive risk quantification is difficult to assess due to the absence of evidence-based guidelines. And we saw that yesterday in our discussion. We don't have good evidence. We do know that there are high levels of DNA damage seen during and directly after treatment. So we know that patients receive chemotherapy, or males receive chemotherapy radiation, they have direct effects, and we need to be cognizant of that when we're talking about when is it safe to sperm bank. We obviously want patients to sperm bank when they can, but we need to have a real honest conversation with them about what that means. And if we can just change our paradigm to say that if we just bank before they receive any therapy, then we don't have to worry as much about this. And Dr. Chemoradiation talked about epigenetic changes that are going to be down the line in that sperm that has received chemotherapy. And similarly, it's been reported, Dr. Meistrich's group and other groups, that sperm DNA breakages are present up to 24 months post-chemotherapy, and so there's a potential that patients may need to wait 24 months. However, The only real guideline that we have is from the European Society for Medical Oncology, or ESMO, which recommends, based on grade C recommendations, so not the best grading, level 4 evidence, that deferral of childbearing for at least 12 months after cancer therapy is the recommendation that we have. So to go back to our case, the patient received leuprolide acetate for menstrual suppression. She received the Nexplanon, yay, for contraception during chemotherapy. Unfortunately, she subsequently relapsed 10 months post-completion of therapy and proceeded to brentuximab, which is a monoclonal antibody treatment, which is direct therapy. Ovarian reserve testing was performed at 1 year post-treatment. Lillian, that she was on a study, and that's why we drew those labs. And her AMH was 0.8 nanograms per ml, and FSH was 8. So 1 year after her initial therapy, she did show some decreased ovarian reserve. However, we don't know yet what to do with that information. She unfortunately did decline referral for further discussion regarding fertility or assisted reproductive technologies, and that was due to social reasons. She had some other things going on with some substance things and didn't quite feel that this was the right time to pursue that. But she is currently alive and well. So some take-home points: contraceptive counseling is not uniformly provided to cancer patients with unfortunate resultant unintended pregnancies. LARCs are safe in the setting of immunosuppression. The caveats are timing of placement of the LARC. Conception after cancer should be delayed for 6 months in females with attention to recurrence risk and maternal health, so we need to put that into the equation. Conception after cancer should be delayed for 12 to 24 months post-treatment in males, again with attention to recurrence risk. This is just the best evidence that we have to date. And that close follow-up of fertility status is important to optimize timing of conception as relates to recurrence and age of patient and partner. And so we know that it is our job to see patients before treatment, during treatment, after treatment, and continue to have conversations with them as their ideas and perceptions and beliefs change throughout that time. And it's also an opportunity for us to capture a window of before they relapse, if they need fertility preservation therapy or contraception. So it's important that we remain actively engaged in the care of our patients. And it's also important that we take into mind the age of the partner. If we're saying that a male is waiting 24 months and his wife is 35 and then she's going to be 37, we need to be talking about what that means for them and educate them appropriately. Thank you for your time. Dr. Appiah would take any questions.
Thanks, Liz. That was so useful and so helpful. And really, just the case that you picked made me just want to bring up an area that's, I think, a larger way of how oncologists deal with fertility preservation that we don't really talk so much about in this forum, which is the alteration of treatment. And so in this instance, BIACOP was the recommended therapy. But in the United States, that's really not a treatment that anybody would use anymore. And the current COG study contains no procarbazine in it at all. And that really is actually driven by a goal to preserve fertility. And so it's a very good anti-Hodgkin's medication, but the toxicities aren't acceptable. And so it's really been removed from the regimens. And so I think there is that perspective. I know oncologists get a bad rap a lot about, kind of referrals and things, but the role that late effects play on thinking backwards about how we should be treating our patients. And by the same token, radiation therapy is now really, with few exceptions, is response related. And so in instances where it would have been a given, it's now, much more thoughtfully considered. And so I think that's really changed, that the fertility in particular has really changed how people think about what we do up front.
That's fantastic. Thank you for sharing that. I was surprised when I saw that she received that. She did.
Yeah, it's going to
Yeah. So.
Yes. Mohamed Khrouf from Tunisia. My question is, what is the value of measuring AMH post chemotherapy. I mean,
Sure.
if we have a very low AMH with a woman with regular cycle, should we advise her to go to IVF instead of natural conception? What do you think about that?
Sure. So I almost left that off my slide because of the controversy, but I just wanted to be transparent. This patient was in a study, and in our study, we were looking at GnRH agonists and the effects on fertility. So we drew baseline labs, gave GnRH agonists, and then drew labs post-therapy. And so the goal was to see longitudinally what that meant. To your point, we cannot predict live birth rates or success of spontaneous pregnancy with AMH levels. AMH levels are used in the IVF world in combination with age and antral follicle count to predict who will respond to stimulation, but we cannot use that and extrapolate that to this data. So thank you for bringing that up, but it was purely research-driven.
Thank you.
Yes, Dr. Gonadotoxic.
Thank you, Leslie. I think that was a fabulous talk. So I've got 2 plugs and 1 question.
Yes.
So I might start with the plugs because I think as I'm an adolescent oncologist, I just look after 15 to 25-year-olds. And I think one thing a really good oncofertility program does is not only allow referrals to gynecologists for fertility preservation, but it allows our young people to see and have a discussion about contraception. And as an oncologist, that has been a really good thing for me to say, yeah, you're going to go and see someone and be followed up. The second thing is many of the people in the room are going to be developing protocols. We looked at American, European and Australasian protocols, and less than 26% of them over the last 5 years have information about contraception. And I think as we develop protocols, we really have to think about these survivorship issues so that, you know, the oncologists who are looking and doing all those toxicity assessments are increasingly thinking about fertility preservation and contraceptions.
Excellent.
So in terms of my question, I have never had a patient with a LARC. And I think for many reasons, so I just want to kind of ask a few more questions. So when I think about contraception, I'm thinking about something that's not only preventing pregnancy, but preventing sexually transmitted diseases, preventing risk to the partner. And for many of my patients, they don't have one partner.
Sure.
And then has low side effects. So I don't want them to have febrile neutropenia, and I don't want them to have thrombosis.
That's a great setup for a response that I'd like to give.
So the LARCs, you know, how, you know, given I've never seen anyone come to my clinic, they're all, you know.
No, that's an excellent question, and I should have included that because in the past, there have been reports of increased risk of pelvic inflammatory disease with intrauterine devices due to the type of intrauterine device, the string. The string we have now is a monofilament string, and the device is different from the devices in the past. So the recommendation of the counseling now is that patients with multiple partners may have an IUD because it does not increase risk of pelvic inflammatory disease except for within the first 72 hours of placement because we're introducing the device. So at the time of placement, we do testing, gonorrhea and chlamydia testing. If we haven't done it before, we use betadine to sterilize the or clean the cervix, and then we insert it and we recommend that they abstain for that period of time. Should they contract an STD while the IUD is in place, the recommendation is that that IUD should remain in place and that the patient should be treated for the infection. It is not recommended to remove the IUD. You may treat. So the old teaching that IUDs were not safe because of the risk of pelvic inflammatory disease is no longer the case with our newer IUDs. And the plug for levonorgestrel IUDs is that the amenorrheic rate is great at 2 years. So every couple of months, the patients begin to have less and less bleeding. So we love to use it for patients with anemia, bleeding disorders, patients who have low counts in cancer. And so it's an excellent device. The implantable rod does not do that. Patients typically can have irregular bleeding, so that's not our go-to. Now the caveat is during cancer treatment, with loss of those follicles and less estrogen, many patients are amenorrheic, so this could be an option. But for the most part, the intrauterine device is great for amenorrhea and is not contraindicated due to risk of infection. Was that your question?
Yeah, that's great.
Okay.
Thank you.
Hi,
Thanks
Kate.
Thanks for your talk, Leslie. It was great. So I just had a question, and maybe you have some guidance on this. In patients that their only option truly is the copper IUD, how do you manage the increased bleeding, if they are bleeding, or breakthrough bleeding, if they have a contraindication to an estrogen pill or even a progestin pill that is, something that we commonly use to treat that breakthrough bleeding?
Right.
And
So
particularly in patients with low counts who
Yes.
may be at an increased risk for bleeding anyhow.
So the only patients that I have, the only cancer patients that I have placed the copper IUD in are patients with breast cancer, because the other patients can receive levonorgestrel, and a lot of those patients are amenorrheic. So they have some spotting, but I've not seen it be heavy enough to be a concern. And that's in the patients that I've taken care of. Hey, Olivia.
Hi, Leslie.
And then I'll have to cut myself off. Right, you go ahead.
Okay, this is it. I've decided I've been too quiet this whole conference, so I was going to get up on the microphone. I have to thank you so much for everything. I am who I am because of this wonderful woman who created our program at Cincinnati Children's. But I want to put in a plug for patient navigators, because you guys all know that's what I love and that's what I do. But I think with the evolution of the patient navigator role and with that focus being on fertility, I think that we've turned into this gynecology advocate as well. And I think as much as I wear the hat with the fertility preservation program, but being kind of that front line and seeing each and every patient, I wear that hat of the kind of onc-gyn nurse. So sometimes I will get pages where I'm like, you guys, this should go to my fellow, but let's talk about what we want to do. I think when you are able to kind of get that first screen and then get them that gyn consult, I know we're blessed because we've got pediatric gynecology, but being able to streamline it right away, where this started to intend to be a fertility consult, but until we can build more of an infrastructure, shout out to the patient navigators to kind of screen and figure out, do they need contraception, and let's talk about IUDs and talk about those types of things. So
Thank you.
Thank
Okay,
you.
Lakshmi, go ahead.
Leslie, thank you so much for that wonderful presentation. So I'm a reproductive endocrinologist, and I just wanted to also state that, contraception is usually not part of our wheelhouse and things that we discuss with patients, but in this unique patient population, when you have a patient that's doing fertility preservation, the time of their oocyte retrieval is a great opportunity to insert a LARC. And I do a lot of IUD insertions because the patient is already under anesthesia. They get effective contraception immediately, and then they can go on to their cancer treatment, and they don't need a second visit.